So this is now your chance to interact. We had the word stock out, and I think that's the time that many people feel that that's what they meet every day. But I'm going to try and having us avoiding talking about stockouts as such, because that's often a very local organizational thing as opposed to the actual availability of a medicine. I need to say one thing before we actually go to questions. Tandy, are you here to help me? Thank you. Is that we did invite a fourth speaker, and that's it's not an elephant, I think it's a planet that's not in the room, and that is the pharmaceutical industry. Because one of the questions we wanted to ask them is that if we came to you and said, like with the benzathine, we're missing it in this country, South Africa, won't you please produce it at a reasonable price, and we will pay a reasonable price so that we can get it for children in South Africa. We haven't had that conversation, and I've tried to engage with one pharmaceutical company saying that's what we wanted to hear, and I don't know why they're not here, and I'm not going to say why not. It may have been an efficiency, it may have been my voice, it might have been a number of things, but they're not here. And it's a pity, because I think as an association, we may need to be making some very loud noises, and I'm hoping maybe it'll be one thing that comes out of here, that we can start to say to our pharmaceutical colleagues, please, we know that MCC registration is an issue, but as we heard from Mariana, there are ways to do that maybe we should be pursuing that. So, questions or comments, please. Put your hand up, and then there we are. Jenny? If you've got it to a specific person, please say so, otherwise it can be a general comment.
Things might just be more general comment. Just maybe 3 comments. I think we are failing the system. I want to take this out of the context of the Western Cape, because I think the Western Cape is very different to the rest of the country. The first issue is about training our staff. And we'll find that, I know in many parts outside of metropolitan areas, community service nurses are working in clinics, and they are having to prescribe, they're having to dispense with very little training and support. We're not managing, because of the COE issue, we're not managing to get post-basic pharmacists out to support the clinics. So I think there's, on the one hand, there's trying to provide excellence and good prescribing and rational prescribing, but on the other hand, the cost, the COE of provinces is not allowing us to provide the right people in facilities to provide support in terms of prescribing. And so it becomes a vicious cycle, because the OS issue, in that we have no records, very poor records in facilities, and I'm talking about CHCs and clinics outside the Western Cape, very poor records about how many patients are on hypertensive treatment. And so it means that nurses literally have to thumbsuck. And they use bin cards erratically. And so when a drug is out of stock, it becomes a scramble. You phone a neighboring clinic, then they give you some, then you add that to your bin card. And so I think we sometimes unfairly criticize the clinic management, but there's just very poor support. And then I've had a situation where, because management is so obsessed with this OS story, is that they will leave a certain number of drugs on the shelf. So your bin card never gets to 0. But the reality is that in the clinics, the nurses will tell the patients that, sorry, there's no medicine available, but the bin card will never reflect that, because it's something that management comes and checks up on. And I've had the situation where nurses come to me and said, I'm sorry, I can't sign this out. And I said, well, is there medicine there? And they said, yes, but there's only 2 bottles left. And I said, a patient needs it. We need to sign it out. And she'll look absolutely horrified and say, but then it goes to 0, and we can't do that. So I think we place so much emphasis on the one hand with EDLs and things, and yet we're not putting money on the other side of supporting and developing structures and the right people to be working in facilities to actually allow the process to be managed effectively. And I'm saying this outside the Western Cape. I think there are enough people managing here, but I've got facilities, CHCs, that don't have pharmacists working in my province. And I think our province to be not necessarily the poorest and the least resourced.
Anybody like to comment from?
I'm sorry to be very critical or negative, But I think we have to define who's responsible. And I was horrified last night with the opening of the Nelson Mandela Children's Hospital and the Minister of Health giving absolute inaccurate numbers of subspecialists in the country, saying there's only 7 pediatric oncologists. Now, fortunately, I know exactly how many there are. Now, if our Minister of Health doesn't know how many are in the country, what are we doing? I'm sorry. And we need to ask, who's responsible for these logistics? I mean, I can go out as a subspecialist and start doing community and training everybody, and this is what I'm doing in Cameroon, just by the way, and I suppose when I retire, I suppose this is what I'm going to do. But we need to get those who are responsible to put the systems in place and get capacity building going, and make sure that our nurses are equipped. And I've worried about this a long, long time, because the dosing is very, very inaccurate. And I'm thinking if we start also, my other part of the talk is we should actively start doing adverse drug event monitoring, because we are going to be horrified of what we're going to get. And this links to your problem.
Thank you. It didn't come up this morning, but it came up yesterday. One of the problems, one of the main killers of young children is, of course, pneumonia, and it stayed so for many years. One of the suggestions yesterday in the community health workers slot was that community health workers actively try and identify children with pneumonia when they go out and commence treatment. And the suggested use was amoxicillin to begin with. Evidence was then shown that this actually decreased mortality from pneumonia. Of course, this gives us a problem whether we should engage with this on a massive scale, since yes, it might decrease mortality in the short term now, but the problems, of course, is with resistance in the medium to longer term, and of course with the decreased ability to identify the organism when they do get to the hospital. So just your views on that?
Thank you very much. So community health workers using medicines beyond vitamin A, which they can now do. Any thoughts, perhaps, Mark?
Yeah, so I think it's worthwhile discussing that within a package of care. So I mean, pneumococcal vaccine and making sure that there's access. I don't think it's a bad discussion to actually have with proper monitoring and evaluation in part of an antibiotic. I mean, we've got a new antimicrobial stewardship program. So if we believe this is good data and we believe it's controllable, I don't think it's a bad conversation to actually have. If we can show a major reduction in mortality, we can look at the process in a couple of years and see if it's working or not. There's many control. You can put a couple of master students onto it, and we can get some research out of it as well. So there's many ways to actually do that. It should come through the group actually up to the process.
This question is directed to Dr. Lawrence. And so the issue of essential drug list, you've highlighted the issue of penicillin, but we've had many other examples in the last year. Vaccines, for example, we've run out of BCG, again because of international supply. We've had to change our measles schedule, not because we think 6 months and 12 months is better, it's again because we ran out of our usual supply of vaccines. So my question really is, so how do we as a country protect ourselves against whether it's penicillin or any of the vaccines? What should we be doing about this? I think you've highlighted the reasons, the many reasons why the supplies aren't coming through. But how should we be responding to the situation is the question.
Nice, easy question. I'm going to speak to the penicillin. I think the idea of not just accepting the fact that the penicillin isn't there. My colleague in Zambia, Dr. Masuku, is a really good example, because he went to, they were doing a big screening program, and he went with facts saying, these are my patients that we're picking up that have evidence of rheumatic heart disease. We know that it works. This is what we need. And he didn't stop. And I think on an individual basis, that's probably what we each have to champion something. I mean, it's champion, whether you're championing BCG or whether you're championing penicillin VK. I think that's probably what you have to do. It has to be try and tackle one problem at a time. I think it's a bit of a facile answer, but that's the best I can do.
So I think we need early warning systems. I think that's really important. So we need to actually predict so in the vaccines a manufacturing problem down the line and how it's going to affect us, and then the regulatory authority can step in with Section 21 globally and get this, so there's no gap. The problem with us is that the pharmaceutical industry don't see us as a massive market, and if they're not making share, we get into trouble. The penicillin is a very important issue. I'll tell you why the penicillin has gone wrong, is that so if you're making penicillin, you can only make penicillin. And so what's happened basically is that if you are a pharmaceutical company and you make penicillin, whichever one it is, you have a dedicated factory. If you don't win the tender, you can't then so you have to close your factory down. You can make nothing else in that dedicated factory. And that's what's happened over here. People didn't think it through. So the companies just closed their penicillin factories down. And to open up another factory, you need to have sustainable. You need to be told that for the next 15 years, for example, you'll make despite tenders and issues, you'll be making all the penicillin for the country. That's what the issue is, because you can't have cost sensitization with pen. And that was a failure of thought. And so that's why we're struggling in our own country.
So it's even more complicated than we thought. We've got one more question. Thank you.
Thank you. Assuming that we can get the logistics and the systems right, what does the panel think about the feasibility of an area of government like the National Department of Health developing its own pharmaceutical manufacturing entity that would be for service rather than for profit, that could supply the country as well as the rest of the continent?
So that has been discussed. It's not a out of the box discussion. So it has been discussed. There are many logistics around that in terms of good quality. What medicines are they going to actually be making? And I think that's where that's kind of got stumped a little bit. Because you rely even for example Roche don't have one factory. Roche in fact outsourced to many factories. Roche in fact outsourced to Supplemedpro factories, for example. So to have one plant may not in fact satisfy, and I think that's what the stumbling block is. For me, that may be a small way forward. I think what we need to do is to collaborate appropriately with the pharmaceutical industry and make sure that they understand the needs that we require. But things have failed on good manufacturing practice. What's happened is that in fact the factories that provide, so in terms of medicine regulation, it's no good just having a dossier which is registered. The factory that produces it on a regular basis needs to be robust. And why we're lacking some of the medicines is that the factories that have been inspected, not in our country, because some things come from outside, in fact failed, which means that if there's a one supply process, it fails for the whole world. So we actually need good factories to be upkept, maybe rather than making our own, we're making our own medicines and reinventing the wheel. Sorry, the MCC can't register medicines. I heard that as part of the discussion. Only an applicant can. So the MCC can't say, well, we like this, so let's register it. They don't have in fact, don't have the legislation around that. Only an applicant, a person who puts a dossier in front of it, can say yes or no. So we are subject to that, because they may just say, well, our market's too small, we're not going to actually register the medicine. You can't go to them and say, well, we demand that you actually do that. It becomes problematic.
I think one of the realities, I like what Mark had earlier on efficacy and effectiveness. One of the realities is, even though it has been discussed, we are actually a free market model, if we want to admit it or not. And so one state-controlled pharmaceutical industry, I think, will pose problems from the free market ideal. And I think the economy is what is driving most things. What surprises me is that everybody is into ethics nowadays, and everybody has ethics discussions and ethics lectures, and everybody is in demand to have in every conference at least one ethics lecture. But nowhere do we get the companies to be ethically accountable for not making sure that certain drugs disappear. And I think it is time that You know, we've had examples in the country of BEE companies. Why can't we say you have to have ethical requirements? You must make at least one dedicated drug that's absolutely essential for the country, like benzathine, penicillin. That is your ethical responsibility, otherwise you can't function in this country. It's just out-of-the-box ideas that I'm thinking of. To get sponsors to be responsible in what they're doing. And they're all forgetting children. Children are not high on their priority list.
Thank you for a very interesting idea. So, Mark, would it be technically possible for the Department of Health to put a dossier with the MCC and say, we want this medicine in the country?
Only if they're applicant.
So they have to register as an applicant.
They have to make the drug themselves. So that's the problem. The Department of Health don't have the constructing law to be able to do that. Unfortunately, you need to be some industry. You can be part of the sponsorship, but you've got to be an applicant.
Thanks for that clarity. Well, ladies and gentlemen, we haven't solved the world's problems of medicines, but I do think that we've had some interesting ideas there that help us understand things better. And as a pediatric community, a child health community, maybe as an association, we can and should have a voice, both for the rare diseases, but particularly for children and children's essential medicines. I think we can learn from this, and it's something that I think the committee needs to take forward in the way that we can do advocacy, even if it's writing an article or asking Professor Creer to write an article for the South African Journal of Child Health. It's just to get it out there and keep the conversation going. Thank you all very, very much. We really appreciate it.